is this artery. Okay, and this ring, this open separated ring, is known as common tendinous ring or annulus of gene. Okay, and it gives origin to four recti muscle. Four recti muscle are superior rectus, inferior rectus, medial rectus, and lateral rectus. These are the four recti muscle originating from the annulus of gene. And it is dividing the superior orbital fissure into three parts. Okay, medial part it contains it gives passage to the inferior ophthalmic vein. Superior was passing through this optic canal, and this intermediate part it gives passage to the upper and lower divisions of the oculomotor nerve, nasociliary nerve, and abducent nerve. Okay. And this lateral part, it gives passage to the superior ophthalmic vein, trochlear nerve, frontal nerve, lacrimal nerve, LFT. This you can remember like LFT, lacrimal, frontal, trochlear nerve, and superior ophthalmic vein. Two veins are passing through the superior orbital fissure. Artery is passing through this optic canal. Okay. Next we go to bony orbit. Boundaries of this bony orbit is, it is pyramidal in shape and it has these following boundaries. It has an apex, base or orbital margin and four valves, medial valve, lateral valve, roof and floor. Apex, now we discuss fissure. This bony valve between these two structures, it is forming the apex of the orbit. These are the different valves formed by different bones. See, apex is directed behind, formed by the body of the sphenoid and the bony bar between the optic canal and superior orbital fissure. Medial valve is thinnest, formed by frontal process of the maxilla, lacrimal bone, orbital plate of ethmoid bone, and body of the sphenoid. And this orbital plate of ethmoid, it is very thin plate of bone. Okay. And this is known as lamina papyracea. Okay, and this what are the important features here? Lacrimal fossa, which is bounded by anterior and posterior lacrimal crest. This will be crest, and anterior and posterior ethmoidal foramina. These are present between the junction between medial valve and roof. Okay. Now lateral valve, it is strong valve formed by zygomatic bone, orbital surface of greater wing of sphenoid behind. These are the features in this valve: zygomaticofacial, zygomaticotemporal foramina, and which nerve? Steward. Okay, individual features we will see in pictures. Now roof. Roof is formed by orbital plate of frontal bone, lesser wing of the sphenoid. And these are the features: fossa for lacrimal gland, trochlear notch, and optic canal. Floor is formed by orbital surface of body of the maxilla, zygomatic bone, orbital process of palatine bone, features the infraorbital groove. It is lying over the floor. Then base is called orbital margin. Okay, which you can see. This quadrangular sepal orbital margin, this is forming the base. How it is formed? It is formed by these bones: frontal bone, anterior lacrimal crest of maxilla, body of the maxilla, and zygomatic bone. So these are the different presenting parts are formed by different bones. Now medial valve. It is the thinnest valve. It is formed by, see here, this is a schematic presentation. See, this is apex and this margin is the base. Okay, margin is formed by, see, up to here it is frontal bone. Here is nasal bone. This is frontal process of maxilla. This small part is the lacrimal bone, and here is the lacrimal fossa. And these lines are the anterior and posterior lacrimal crest. Anterior lacrimal crest is lying over the frontal process of maxilla. Posterior lacrimal crest is lying over the lacrimal bone. And this part is orbital plate of ethmoid. This is very thin and also known as lamina papyracea. And this is sphenoid bone, orbital plate of sphenoid forming lateral valve, and this is lesser wing or body of the sphenoid forming the apex. Here lies the zygomatic bone, orbital part of the zygomatic bone, and this is orbital plate of the maxilla. And over the maxilla, there lies the infraorbital foramen. And this is over the floor of the orbit, where this is infraorbital canal, through it passes the infraorbital vessels and nerve. Okay, and they are coming out through this infraorbital foramen. And here you can see this is zygomatico or facial. It is lying over here, and zygomatico temporal foramen. That will also lie. And here these two foramina between this roof and the medial wall. These are the position of anterior and posterior ethmoidal foramina, and through it passes the anterior posterior ethmoidal vessels and nerve. Okay, and along the lateral margin, here you can see one tubercle that is known as Whitnell's tubercle. Okay, it gives attachment to some ligament, lateral check ligament. Okay, and here over the foramina they lie at the junction of medial wall and roof of the orbit, and they transmit the anterior and posterior ethmoidal nerves and the vessels. See here, this is the section, coronal section through the orbit. This is showing the medial wall. See, these are the two foramina, anterior posterior ethmoidal foramina. This is lamina papyracea or orbital plate of ethmoid. Here is the lacrimal bone. This depression is lacrimal fossa formed by anterior posterior lacrimal crest, and this is orbital plate of maxilla forming the floor, and this is frontal process of the maxilla. Next we go to the lateral wall. It is a strong wall, consists of zygomatic bone in front, orbital surface of greater ring of the sphenoid behind. These are the features: zygomatico-facial, zygomatico-temporal foramina. For the zygomatico-facial and zygomatico-temporal nerves, they are present respectively. Now, Whitnell's tubercle. Lateral wall, you have seen Whitnell's tubercle. It is a small bony tubercle located just behind the orbital margin and slightly below the frontozygomatic suture. You have to show this tubercle, position of the tubercle, where it is lying during showing the bony orbit. Okay. Attachments, it gives attachment to lateral palpebral ligament, check ligament of lateral rectus muscle, suspensory ligament of eyeball, and levator palpebral superioris muscle. Okay, so these are the attachments of Whitnell's tubercle. Now roof. Roof is formed by orbital plate of the frontal bone in front and lesser wing of the sphenoid behind. These are the features of the roof. Fossa for lacrimal gland located in the anterolateral part of the roof. Previously we have discussed lacrimal sac is lying in the lacrimal fossa, and in the anterolateral part of the roof there is fossa for lacrimal gland. Okay, so sac is lying medially and gland is lying laterally. Trochlear notch or spine is located at the anteromedial angle of the roof. Attachment, it gives attachment to pulley for superior oblique muscle of the eyeball. Now, optic canal is situated at the extreme posterior part of the roof. It transmits optic nerve with meningeal sheath and ophthalmic artery. Now, floor, it is formed by three bones: orbital surface of body of maxilla, zygomatic bone anterolaterally, and orbital process of palatine bone posteromedially. Okay, so these are the bones forming this floor. Now, important features are infraorbital groove and canal transmit the infraorbital nerve and vessels from infraorbital fissure to the infraorbital foramen. An impression of origin of inferior oblique muscle lies just lateral to the opening of the nasolacrimal duct. Okay. Now we go to the base or orbital margin. Base of the orbital margin. Base of the orbit, it is formed by the orbital margin. It is open and quadrangular. What are the boundaries? Supraorbital margin, in medial orbital margin, lateral orbital margin, and infraorbital margin. Okay, so what are the structures forming this? Supraorbital margin is formed by frontal bone. It has a supraorbital notch or foramen at the junction of lateral 2/3 and medial 1/3, and it transmits the supraorbital nerve and vessels. The medial orbital margin is ill-defined, formed by frontal bone above and anterior lacrimal crest of maxilla below. Infraorbital margin is formed by zygomatic bone laterally and maxilla medially, and on medial side it is continuous with a vertical reef called the anterior lacrimal crest. And lateral orbital margin is formed by zygomatic process of frontal bone above and frontal process of zygomatic bone below. These are the relations of orbit. You can see from the relations that air sinuses of our body, air sinuses are lying just around or in between the orbits. You can see here, superior relation to the orbit is anterior cranial fossa and part of frontal air sinus. Inferiorly lies this maxillary air sinus. Medially lies ethmoid and sphenoid air sinus, and laterally there is temporal fossa in front and middle cranial fossa behind. Okay, so these are the relations of orbit. Now we go to some interesting facts. Visual axis, which is also asked in your bio. What is visual axis? It passes through the center of the anterior and posterior poles of the eyeball. This is eyeball. It is mainly slightly oval. Okay. It is a sphere-like structure but slightly oval. Anteriorly, this is anterior pole, this is posterior pole. So the axis passing from anterior to posterior pole is forming the visual or optical axis. Orbital axis, it passes through the apex of the orbit and the center of the base of the orbit here. This red line is forming the orbital axis. So these two are different. You can see visual axis and orbital axis is passing through the apex of the orbit and mid of the base. And the angle between the visual and orbital axis measure about 20 to 25 degrees. This angle is 20 to 25 degrees. Now orbital index. Orbital index is measured. It is anthropometrically it is measured. Okay? Equal to maximum orbital height divided by maximum orbital breadth into 100. This is how orbital index is measured. Now, different fascia, orbital fascia. Important fascias are orbital fascia or periorbita and bulbar fascia or tenor's capsule. Okay, the periosteum of the orbit, it forms the orbital fascia or periorbita, and as it is loosely attached to the bones, it can be easily stripped and it forms a funnel-shaped sheath around the orbital cortex. And posteriorly, it is continuous with the dura mater around the optic nerve. At the opening of the orbit, it is continuous with the periosteum of the adjacent bones. Now, lacrimal fascia, it is derived from orbital fascia and it covers the lacrimal fossa. And this lacrimal fascia gives attachment to medial palpebral ligament and lacrimal part of orbicularis oculi. Next is bulbar fascia or tenor's capsule. It is the inner layer of the orbital fascia in the orbit that forms the fascial sheath of the eyeball. Okay, and it is thin. See here, this is globe of the eye. Okay, this is optic nerve. Okay, the layer of the fascia which is covering the eyeball, that is known as bulbar fascia or tenor's capsule, fascial sheath of the eyeball. And see here, this sheath is also continuing along the optic nerve. Okay, and the fascia covering the wall of the orbit, that is known as orbital fascia. So you have seen the two locations of these two fascia, and these are the orbital septum. These are extending within the eyelids. Okay, these are also fascial sheaths or fascial plates. And here this fascia will continuous posteriorly, forming a sheath around the optic nerve and will be continuous with the dura mater. Okay, so tenor's capsule is inner layer of orbital fascia in the orbit that forms fascial sheath of the eyeball, and it is a thin, loose membranous sheath around the eyeball, extends from optic nerve to the sclerocorneal junction or limbus. And tenor's capsule is pierced by this structure. This is very frequently asked. Tendons of extraocular muscles, ciliary vessels and nerves, and optic nerve. These are pierced in this tenor's capsule. Okay. Now, important features here: orbital is muscle, orbital septum, fascial sleeves of the extraocular muscle, medial cheek ligament, lateral cheek ligament, and suspensory ligament of the eye. All these are attached to this fascia, and some parts are the modifications of this orbital fascia. Okay. Here, some structures you can see. Here is the lateral cheek ligament, which is attached over the Whitney's tubercle. Okay, and this is medial cheek ligament. Two recti muscle, medial lateral recti, and this structure is known as this horseshoe-shaped structure. This is known as suspensory ligament of Lockwood. And within this ligament, like these two muscle, inferior rectus, inferior oblique. Schematic diagram of the previous one. Now we go to the extraocular muscle. This comes as a long question. You practice very carefully. Okay. Extraocular muscles comes as a, and bony orbit is important for your viva. Okay. Head neck viva. It will be asked bony orbit. Extraocular muscles is important for a theory question. Comes as a long question. So the extraocular muscles of eyeball are classified into two groups: voluntary muscle, involuntary muscle. Voluntary muscles are 7 skeletal muscles, and these are 4 recti muscles: superior, inferior, medial, lateral, rectus. 2 oblique muscles: superior oblique, inferior oblique, and 1 levator palpebrae superioris muscle, which is muscle of the upper eyelid. Okay, so these 7 muscles are the voluntary muscles. Then involuntary muscles, there are 3 involuntary muscles, smooth muscles. The superior tarsal or molars muscle, inferior tarsal muscle. Okay. See the location of the muscles. See around the below 4 recti. According to their position, their names have been given. Superiorly superior rectus, inferiorly inferior rectus, laterally lateral rectus, medially medial rectus muscle. Okay, and this hooking around this muscle is the superior oblique. Okay, and this inferiorly, this is inferior oblique. You can see this is the trochlear pulley. Okay, through this pulley passes this superior oblique muscle, and this is levator palpebrae superioris going to the upper eyelid where it has been cut. Okay, so you have to write down for long question all these things. Origin, insertion of all the recti oblique muscle and levator palpebrae superioris. And their nerve supply is very, very important. All the voluntary extraocular muscles are supplied by, voluntary means those 7 muscles, 4 recti, 2 oblique and levator palpebrae superioris supplied by oculomotor nerve, that is third cranial nerve, except LR6. Lateral rectus is supplied by abducens nerve, and SO4 superior oblique is supplied by trochlear nerve. Okay, so you remember LR6, SO4, rest 3. Okay, rest of the muscles are supplied by third cranial nerve or oculomotor. Okay, understood the nerve supply. So these are the origin. You remember 4 recti muscle was originating from common annulus tendinous ring or annulus of Gill. Insertion on the sclera posterior to the limbus in front of equator of the eyeball. Oblique muscles are superior and inferior oblique. Superior oblique origins from body of sphenoid and superomedial to the optic canal. And insertion on sclera behind the equator of eyeball in posterior superior quadrant. Inferior oblique orbital surface of the maxilla is the origin, and on sclera behind the equator of the eyeball in posterior inferior quadrant is the insertion. You can see posterior superiorly insertion of superior oblique, posterior inferiorly insertion of inferior oblique. Okay. Levator palpebrae superioris origin from lesser wing of sphenoid anterior to the optic canal, and superior lamina, these are the insertion. Superior lamina, skin of the upper eyelid, anterior surface of tarsal plate. Inferior lamina forms the superior tarsal muscle. Superior tarsal muscle is a deeper part of levator palpebrae superioris muscle, and that is inserted on the upper border of superior tarsal plate. Innervation, sympathetic fiber from T1 segments of spinal cord. What is the action? Elevation of the upper eyelid. Denervation of this superior tarsal muscle in Horner syndrome, that is T1 fiber injury, results in ptosis or drooping of the upper eyelid. Ptosis is drooping of upper eyelid. The inferior tarsal muscle, it is smooth muscle that extends from the fussel sheath of the inferior rectus and inferior oblique to the lower margin of the inferior tarsus. Now we will discuss individually this recti muscle. Origin, see, this is superior orbital fissure. The red rounded structure is the position of annulus of Gill. And here is origin of the, just above the annulus, medially, here is origin of superior oblique, and here is origin of levator palpebrae superioris, and here is origin of the over the orbital plate of maxilla, origin of inferior oblique. Okay, so all the recti muscle origin, all the recti muscle arise from common annular tendon or tendinous ring of Gill, and this ring is attached to the middle part of the superior orbital fissure. It was dividing the superior orbital fissure into three parts: medial, intermediate, and lateral. Lateral rectus has two heads. One arises from tendinous ring, another from the orbital surface of greater wing of the sphenoid bone, lateral to the tendinous ring. Insertion, you see, all the recti muscles are inserted into the sclera little posterior to the limbus. Limbus is cleocorneal junction, and in front of the equator of the eyeball. The distance from the limbus and the insertion of recti muscle is as follows. Medial rectus 5.5 centimeter away from the limbus. See here, this is medial rectus 5.5. Then it is rotating clockwise. Inferior rectus is 6.5, lateral rectus is 7, superior rectus is 8. Okay, 5.5 medial, then inferior 6.5, lateral 7, superior 8. Clockwise it is rotating. Okay, the distance. Distance are actually important for your MCQs. Now, oblique muscles. Two oblique muscles are present: superior and inferior oblique. Origins from the body of sphenoid, superior oblique, from body of sphenoid superomedial to the optic canal. Here, this is superior oblique muscle. Okay, coming from posteriorly, and this muscle runs forward to form a tendon that passes through the fibrocartilaginous pulley attached to the trochlear fossa. Here lies the pulley. Okay, this is looping around this pulley. Trochlear fossa of the frontal bone, and further the tendon passes laterally, downward and backward. Inserted into the sclera behind the equator of the eyeball. Okay, it is looking around this and going posteriorly again and inserted on the posterior part of half of the glute in the posterior superior quadrant. The inferior oblique originates from orbital surface of maxilla and lateral to the lacrimal groove. Direction of fibers passes laterally, upward, backward, below. See, this is the inferior oblique. Here it is originating, going laterally, upward and backward. Below the inferior rectus, here is inferior rectus is lying below it, and further deep to the lateral rectus muscle inserts in the sclera behind the equator in the posterior inferior quadrant of the eyeball, a little below and posterior to the insertion of superior oblique. So these are the origin insertion of 4 recti and 2 oblique muscles. Levator, next muscle is levator palpebris superioris, 7th muscle of the voluntary muscle. Okay, so it is a muscle of upper eyelid. It is thin triangular muscle, originates from lesser wing of sphenoid above and in front of optic canal. Direction of fibers: the fibers run forward and split into superior or voluntary lamina and inferior or involuntary lamina. Insertion: the fibers of superior lamina, they pierce the orbicularis oculi muscle and inserts on the skin of the upper eyelid. And few fibers are inserted on the anterior surface of superior tarsal plate. And the fibers of inferior lamina are smooth muscle fibers and that of the superior tarsal. It is inserted on the upper margin of superior tarsal. Now here is the innervation. All the voluntary extraocular muscles are supplied by oculomotor nerve. With that one, SO4, LR6, rest is supplied by oculomotor. Superior oblique trochlear nerve, lateral rectus abducens. And involuntary muscles of the eye are supplied by postganglionic sympathetic fibers from the superior cervical ganglia. So these are the nerve supply of all the orbital muscles. See here different recti. See superior, inferior, medial, lateral recti from originating from the annulus of Jean. And here is the levator palpebris superioris. Here is superior oblique. Here is inferior oblique. 7 muscles. Okay, these 7 muscles you have to write down if you are asked extraocular muscles. And now what are the actions? Actions are very important. You have to test in your ophthalmology which muscle is paralyzed in your patient. Okay, so movement of the, so you have to know the action of all these muscles. So eyeball moves along the following 3 axes to perform as follows. Around the transverse axis. Okay, elevation. See here passes the transverse axis. Around this axis, elevation or depression can be done. Elevation or upward rotation depression or downward rotation. Next, around a vertical axis. Here will be the vertical axis. Around it, laterally or medially, it can rotate. Okay, so adduction. Adduction means coming to the midline. It is medial rotation of the eye, and abduction is away rotation from the midline. So that is abduction of the eye. And around the anterior-posterior axis, anterior-posterior is passing through the two poles, the anterior and posterior pole, and around it, it can occur rotation, intorsion or extorsion. Intorsion is medial rotation of cornea from the its 12 position, and extorsion is lateral rotation of cornea from its 12 position. Okay, so these are the functions of different recti, oblique, levator, palpebral, superior. Superior rectus causes elevation, adduction, intorsion. Inferior rectus, depression, adduction, extorsion. Superior oblique, depression, abduction, intorsion. Inferior oblique, elevation, abduction, extorsion. And you can see here, medial rectus is sole function adduction, lateral rectus will pull laterally, there will be abduction. You can see here two oblique muscles are causing abduction, okay? And superior and inferior rectus muscle are causing adduction, okay? Now this levator palpebral superioris, it is causing elevation of upper eyelid to open the eye. See, this is normal position of the eye. Superior rectus is causing this position, causing elevation, adduction, intorsion. Inferior rectus is causing this depression, adduction, extorsion. Both are causing adduction. Okay, this is causing elevation, this is depression, here is intorsion, here is extorsion. Then medial rectus is causing sole adduction. Okay, only adduction is done by. Lateral rectus is causing only lateral abduction. Okay. And according to nerve paralysis, if LR6 abducens nerve is paralyzed, there will be squint. Okay, squint, so the eyeball will lie in this adapted position. Lateral rectus paralysis occurs. Then superior oblique, it is causing depression, abduction, intorsion. This will be the position. And inferior oblique is causing elevation, abduction, and extorsion. You can see the of the eye, it is located, or cornea is located on the near the lateral angle of the eye. Okay, so these are the actions of individual muscles of the eyeball. This is very, very important. These actions are very important. So on the different movements, conjugate movements occur when both eyes move in same direction with the visual axis being parallel. Disconjugate movements occur when the axis of both the eyes converge and diverge around the vertical axis. And single or pure movement of eyeball is produced by combined action of different muscles, either by addition or nullification of the action. And these are elevation, depression, abduction, intorsion, extorsion. Elevation is done by superior rectus, inferior oblique, superior rectus in abducted eye, and inferior oblique in adducted eye. Depression is done by inferior rectus, superior oblique, and inferior rectus in abducted eye, superior oblique in adducted eye. Adduction is caused by medial rectus, superior, inferior rectus. Abduction by lateral rectus, superior, inferior oblique. Intorsion is done by superior rectus, superior oblique. Extorsion by inferior rectus, inferior oblique. These are the clinical aspects. Okay, strabismus or squint. Unilateral paralysis of individual extraocular muscle produces strabismus or squint. It causes deviation of eyeball to the opposite side due to unopposed action of the non-paralyzed muscle. There will be diplopia due to squint, diplopia or double vision, as the light from the object will not be focused on the identical areas of both the retina. And there will be paralysis of lateral rectus due to damaged abducens nerve resulting esotropia or medial squint, internal strabismus. And diplopia appears on looking to the paralyzed side. Paralysis of medial rectus, it is due to damage of the oculomotor nerve results in exotropia. Diplopia appears on looking to the unaffected side. According to these symptoms, you have to identify which nerve is paralyzed. And according to previous concept, terms like medial squint or internal strabismus and lateral squint or external strabismus are currently not in use. And nystagmus, what is nystagmus? Is an involuntary rhythmic contraction of the eyeball. Okay, they are continuously moving from medial to lateral. See, this is normal eye. Here is extropia in this eye, left eye. Extropia of left eye. Okay, that's one. Any queries? Okay, so bony orbit you read for your Viva and MCQ, that part. And extraocular muscle, very important. Their origin, insertion, nerve supply, and actions are very important. It will also be needed during your ophthalmology third part 1. Okay, so you prepare it for a long question. Extraocular muscle comes as a long question. Understood? Okay, that's all for today.